Dear healthcare professionals, in this video I am going to share with you sixth case in the series on diagnosis. The series of interesting, uncommon and challenging cases which I came across while working in critical care. Videos are helpful for all healthcare professionals. I will share a real case that was presented to our hospital's emergency. In this case, the simple omission of not identifying underlying cause would have led to incomplete treatment, therefore possibility of poorer outcome. I will walk through real scenarios so you can connect this story with real-life clinical situations. So, let's embark on this story of making the uncommon, interesting, and challenging diagnosis and how it impacted the patient's management and the outcome. Let's begin with our case. A 38-year-old man presented to hospital emergency with acute onset of dizziness and vertigo. Initially, case was seen by emergency physician and subsequently by neurophysician. MRI brain was conducted, and diagnosis of left posterior circulation ischemic stroke was confirmed. Thrombolysis could not be given to the patient because of delayed presentation. So, he was started on aspirin and statin and shifted to intensive care unit. There was no past history of diabetes, hypertension, heart disease, stroke, seizure. Patient was a bodybuilder and used to take multiple different supplements and steroids. During next day morning round, while visiting patient, he complained of pain in left hand fingers. Though radial pulse was present, his left hand was colder than right. Since pain in the hand was also on the same side as posterior circulation stroke, the common reason for both was suspected and based on vascular anatomy and no involvement on the right side or in the left common carotid artery distribution. It was suspected that the likely cause is thromboembolism and likely site of thrombus is either vascular area between left common carotid and left subclavian artery or left subclavian artery itself before the origin of left vertebral artery, explaining both left vertebral artery occlusion as well as left hand ischemia. ICU team decided to do CT aortogram to look for any possible thrombus in aorta at the specific sites. Our suspicion turned out to be true. There was thrombus in the area between left common carotid artery and left subclavian artery. We stopped aspirin and started him on therapeutic dose of low molecular weight heparin. 2 days later, he developed severe abdominal pain in left upper abdomen. We suspected splenic infarct and planned for CT abdomen. CT abdomen was done emergently, and it was reported as normal. The normal abdominal CT was not correlating with our clinical suspicion, so we decided to discuss with radiologist. We conveyed our clinical suspicion to radiologist and then, radiologist re-evaluated the scan and confirmed the presence of splenic infarct. As the patient's pain was severe and there was no improvement with paracetamol and ketorolac, he was initiated on opioid analgesics as an infusion. We also started him on unfractionated heparin infusion and stopped low molecular weight heparin. Patient improved in next 3 days' time and he was shifted out of ICU with the advice to stop all steroids. He was continued on oral anticoagulation at discharge with the advice to visit cardiovascular surgeon. So, what was the diagnosis of this patient? Left posterior circulation stroke, left hand ischemia, splenic infarct, or something else? What could have been possible if we treat the patient for stroke only and unable to establish an underlying etiology causing hand ischemia and stroke both? Not knowing the underlying cause could have led to inadequate treatment and possibility of recurrent embolism to left posterior circulation, left upper limb, abdominal organs, or even to lower limbs. Moreover, the clot could have increased in size at the site of origin itself. After establishing diagnosis, we stopped aspirin and started low molecular weight heparin. By establishing the underlying cause of ischemia at 2 different sites on the same side, hence, by establishing the correct diagnosis, we were able to prevent likely morbidity and mortality. So, diagnosis of this patient was not posterior circulation stroke or left hand ischemia or splenic infarct but aortic thrombus. Posterior circulation stroke, hand ischemia or splenic infarct was a finding and dizziness was a presentation. As the diagnosis became apparent, we added anticoagulant drug. We were also immediately able to diagnose splenic infarct as we were aware of context, and this was the reason we discussed with radiologists specifically about splenic infarct even when CT abdomen was reported normal initially. So, diagnosis was helpful in optimizing long-term management plan. So, establishing an underlying diagnosis is an essential component of treating patients. Healthcare professionals should be cognizant of the difference between diagnosis, findings, and presentation. Misdiagnosis or no diagnosis can lead to incorrect treatment, complications, and potential morbidity and mortality. Hope this was an interesting case. If you like this information, please subscribe to this channel for more interesting and challenging diagnosis.